So, Chapter 12, Critical Thinking and Clinical Decision Making. Talking about some introduction stuff, so this is what we're going to be talking about is, as a paramedic, you must be able to identify problems, and this is going to be on a daily basis, be able to set patient care priorities, develop a care plan, and then execute that plan. So in the past, cookbook medicine has been kind of normal, and at some places it might be, but the idea is that you get enough knowledge and you become good enough at critical thinking skills that you're able to not do that. And what do we mean by cookbook medicine? Well, essentially, we're just talking about somebody that just basically blindly follows some steps without fitting them to the specific circumstance involved. So essentially what we're saying is a guy who has a patient that has chest pain and they immediately follow the chest pain protocol or chest pain algorithm rather than figuring out if this patient is appropriate for this. So still continuing on with the introduction, you're expected to provide quality patient care. We're going to be talking about that. Moving on to our first section, our first portion here, we're talking about gathering, evaluating, and synthesizing information. So what we're saying is that the first cornerstone of your practice is going to involve gathering, evaluating, and synthesizing information. So you must be able to communicate and obtain information from many types of patients. So we're talking about different age groups, different educational backgrounds, different abilities to communicate. Patients who've consumed drugs, they have language barriers, hearing impairments, a lot of different things. Then you also need to be able to assess and evaluate gathered information to develop a treatment plan by checking the validity of the information using your judgment and communication skills. So, we're going to be making sure that things are as they seem, using our judgment and using our history that we've, ran this type of call and we see this. So there's a lot of different things really at play here. So the way you're going to evaluate the information that you obtain, we're going to evaluate the scene, the patient, we're going to evaluate a bystander. Within that, we're going to determine what information is valid and what's invalid. We're going to process or synthesize the information. So we're going to take in all of that information and see kind of how it fits. So for an example, a 64-year-old man reporting chest pain. So he's type 1 diabetic since childhood. He started smoking in high school and has COPD since he was in his 50s. He's a longtime smoker. Like I said, he has COPD since his 50s. So this is kind of just this example. So a comorbidity, you'll see that word later, but this is where it applies. And what we're talking about is when a patient has 2 or more chronic diseases or condition, then that's called a comorbidity. So diabetes, we know that diabetes is directly related to circulatory complications, and now we're also talking about a chest pain patient. So there's some real issues. So diabetes, we know, often leads to the development of vascular disease, a lot of different things going on. So, we can have some real issues because of diabetes as well as cardiac reasons. So, a lot of different things here. You see patient history, they have diabetes, have circulatory disorders, and then abnormally high or low blood glucose. Patient history, COPD, chronic hypoxia, chronic hypercarbia. So if you remember our hypos and hypers, hypoxia going to be low oxygen, and then hypercarbia going to be high what? CO2. So they're, those two, for the most part, typically are inversely proportionate. And then our current signs and symptoms are going to be chest pain. And we start synthesizing, start working through this different information, trying to come to at the end game, trying to come to our answer. So we're moving on to developing and implementing a patient care plan. So kind of the second cornerstone, we use the word cornerstone, but your paramedic practice is your ability to develop and implement a treatment plan. So after you've determined the patient's primary problem by identifying the chief complaint and then establishing your working diagnosis, your treatment plan is guided by a couple of things, right? Patient care protocols as well as standing orders. There's some other things really that starts to do that too, and that's, hopefully we're going to start recognizing some of these things, whether this patient fits into this category and if there's a reason that it should fall into the cardiac category versus chest wall pain, or all of those things. But see, this last point is protocols or standing orders. They define the essential clinical standard of care. So that's kind of where we're going to be working from, and at times working to. So it's kind of encompassing and covers everything. So they're going to be doing a lot of different things talking about these protocols and standing orders. So they have performance parameters of when and how we should do certain things. You also they promote a standard approach and quality of care. They do not cover atypical presentation. So just pretty much those everyday type calls, but they're not going to cover the wacky calls that sometimes that we see, They also provide parameters for medical control. So, it could be if you need to call your medical control officer for this, or you need to call your doc for that. There's a lot of different things that these things address. Using judgment and independent decision making. So that's going to kind of be our third cornerstone of paramedic practice, and that's judgment and independent decision making, or another word you might have heard is autonomy. So, for an example, I don't think it's on here. No. So an example, we're going to talk about called to a factory where a machinist was injured on the job and has a serious gash to the upper part of his leg. Substantial amount of blood is gushing from his femoral artery. So in this situation, it's best to delay contact with medical control until the bleeding is controlled and you're en route. So, at times when we think about we've got to call med control, at a specific time and at a very specific point, it's not always necessarily the case, because as you see here, we've got to immediately recognize and treat life threats, and that's what we're there for. Hopefully we're going to be working in a service and have enough trust that we don't have to call the medical control officer or doc, with every single thing. So our next point, we're talking about thinking and working under pressure. You'll see that picture that I've put down at the bottom. What I like to talk about is that as a paramedic, this is one of the big things that we need to be able to almost kind of mimic. So when you see a duck that's swimming on the water, you notice above the water, he is very calm, cool, and collected. You wouldn't know what was going on underneath the water unless you looked. But when you see underneath the water, you see he is moving around. His feet are going left and right and forward and backwards, and he's just constantly moving. So what my challenge is, or let me back up, how I relate that is when we're on scene of a serious call and something that's overwhelming us, we need to be much like this duck is, which is cool, calm, and collected on the outside. On the inside, if you're a little spun out and wound up, that's perfectly okay as long as you're not acting that way outside. Because here's the thing, all the first responders and everybody that's on scene with you is going to be looking to you to set the tone. So if you're leading this cool, calm, and collected, then they're going to feel confident that you have your stuff together and will be able to handle this scene and be able to move forward. So I like this analogy for the way we should be on these scenes that are very, I shouldn't say exciting, but very intense. So, some of the things is thinking and working under pressure. So to avert disaster, you must have some knowledge. We need to have some knowledge of the things that is going on, for anatomy and physiology type knowledge, the way the body works knowledge, pathophysiology, pharmacology, all of these different things we have to know that, as well as be an excellent clinician. So you see the point, excellent clinical skills. We also need to have some excellent clinical skills so we can perform the procedures that we need to and recognize that when someone is sick. And in my opinion, one of the most important skills that we can have as a paramedic is to recognize when we're in over our heads, and just to be able to recognize that this man or woman or child is sick and they need to get to the hospital now. It doesn't really matter that we know exactly what's going on, but we recognize that this person is a train wreck, and we're able to then do our general supportive care type stuff, IVs and O2 and some monitor and look at everything. But more importantly, get them to where they need to go. So some of the things that, we just said, we must be able to work under extreme pressure. We must be able to analyze this situation. And then we also must be able to perform quickly and efficiently. So thinking about the range of patient conditions, we must be able to determine if the patient is sick or not sick. And that's become a really big thing, is a lot of times people are having a hard time determining whether someone is sick or not sick. And that's part of the changes that we're seeing within the National Registry and the testing, the different modalities of the way that we're testing. So now we have one large scenario versus all of those separate skills, because National Registry and employers and FTOs and supervisors are realizing that people are able to come out and do an intubation, but let me remind you, you've probably never been called to the scene of an intubation. Or you've never been called to the scene of a talk, where you're just going to talk through something. We are being called to the scene of a car crash, and someone needs to be rescued, or somebody needs to have some medical procedure done. So at the end, after saying all of that, one of the things is, if we determine that they are sick, we also need to be able to quantify that, meaning determine how sick they are. So are they, on the doorstep of death type sick, swirling the drain, or are they sick, but, they're not that sick to where we can kind of stay in place? So this has become one of those conversations. The words we used to use was load and go or stay in place. So, we're talking about critical or stable and unstable, those type of things. So, clear thinking whenever this happens is a big deal, and much of that just starts with triage that allows us to be able to do some very quick things, get people triaged, and get them in the place that they need to go. So you'll see that, you'll see on here the listings of this patient in critical condition. That's going to be red. We also, and those are people that are going to need to be transported immediately, because there's a really good chance that they're going to die. Patients that are in unstable condition, and they need to get going. So then patients in unstable condition, moving from critical, but unstable, meaning these guys, they could temporarily delay their transportation by a few minutes to possibly the next half hour. Those patients are able to kind of go under the yellow, and you have your own system that you'll use at your service of how you start doing these. But then we go into black tags, which is mortally wounded or dead. So somebody that's going to die, and we're unable to devote a lot of resources towards that person, because it's going to affect all of the other people that we're there to take care of. Those are going to be black tags as well. And then we have walking wounded or minimally injured. So those are going to be green tags. So life threats, when we talk about life threats, those guys, we're talking about multi-system trauma, major multi-system trauma, devastating single system trauma, so, one really big injury, end-stage disease presentations, acute presentations of a chronic condition. So unstable conditions include serious multi-system trauma, acute presentations of a first-time medical event, MI, those type of things, multiple disease etiologies, non-life-threatening, simple abrasions, partial thickness burns, small lacs. So let's continue on with this. We've started talking about our critical thinking. Let's continue on with that, moving off of our triage, the different patient conditions that we might see. But part of that next step is that concept formation. So really the first stage of the critical thinking process is going to be concept formation. So when does that arrive? Which is going to be when does that start? Is when you arrive at the scene. Right away, hopefully you're going to become situationally aware of what's going on. You're going to evaluate the scene to ensure the safety of you, your crew, your patient. That's going to be the biggest thing that can harm us, which is our scene safety. So anymore, it's not good enough just to walk in on a scenario or while you're in the lab. And I believe I've spoke to this already, but if not, I'll make sure I go into it. And we're not going to hold up our hands and say BSI scene safe. We need to make sure that we have our gloves on because we're going to play just like we practice. And then we are also going to look for anything that might cause harm to us, or we're going to ask if the scene is safe or is there something there that could harm one of our crew members. So we're going to move on past that BSI scene safe thing, and we're going to start determining whether the scene is safe because that's how we do out in the real world. So, we said we're going to gather this information, and then this all begins as we arrive on scene. So then the primary survey, it identifies and corrects any immediate life threats related to our A, B, C, D, and E. And we already understand that when we got into patient assessment. Our ABCs are really big things. That is what actually kills people really quick, is if we are not able to do that. So the next thing we want to kind of find out that's going to help build this concept, or I guess the right word, build this concept, is the sample history. So pertinent medical history, any meds the patient's taking, the patient's affect, meaning how they're interacting with you and how they're interacting with the scene and all of that. And then vital signs and relevant clinical test results. That's when those guys are obtained after that. So then we move on to our next step, which is our data interpretation, second stage of the critical thinking process. We evaluate all the gathered information and form a conclusion. So one thing that a paramedic should understand is how the body works and how it responds when complications arise. We should have a solid background in anatomy, physiology, pathophysiology that's able to help us start processing all of that information. But we really need to understand how this stuff happens. And then another key element is your level of education experience before coming to the paramedic program. So many times, an EMT might have spent several years out in the field, and they have already seen a lot of things and have already started this critical thinking process, so some of these things might be a little easier for them. They also, though, bear the weight of seeing how things have been done wrong for quite a while. And now they may end up picking up some of those bad habits and have to get those corrected and all of that. So it's a give and take kind of thing. But to be honest with you, it's not listed here, but one of the biggest things about this is having a good attitude. And so if you've been on the scene a long time or been doing this a long time or not, having a good attitude and wanting to learn and all of that is going to help you through that critical thinking process, because you're not always thinking the worst and looking for the worst of these situations. So moving on to the third stage of critical thinking, we're going to talk about the application. This is where our field impression that becomes a working diagnosis. So we have a few different ideas, hypothesis, some different things that we've talked about within our assessment, our differential diagnosis, all these different things. But we start now whittling these down to a working diagnosis. And what we're talking about is it's kind of what you tentatively believe to be the problem and focus of your treatment. So that working diagnosis, it could be a number of things, from your differential diagnosis and then the conditions from which you're treating the patient. It can be you just start moving that direction and kind of just whittling it down. But that treatment plan that we're talking about, that's going to be determined by patient care protocols and or your standing orders. So moving on to our last piece of, there's two really, but the fourth, the reflection and action, is the fourth stage of the critical thinking process. It's actively treating the patients while monitoring their intervention effects. So, one thing is when you give your morphine to somebody or fentanyl to a chest pain patient, you're monitoring to see how effective it was. Did it decrease their pain? Did it decrease their anxiety? What's their blood pressure doing? All of those things. That's going to be really important for you to document for a couple of reasons. One is, while you're in paramedic school, it's required because it's professional and because it's needed. But is just as importantly, when you get out in the field and you give meds and you're running these calls and you do your documentation, if you don't put that on there, sometimes these calls can get kicked back because these insurance companies want to know what that medication did. So when you say that they had chest pain of 10 of 10, you gave them, a little bit of fentanyl, 50 mics of fentanyl, then their chest pain is now 5 of 10 and it decreased their anxiety or whatever. So you're going to need to make sure that you're documenting that within your paperwork, your PCRs. Also, so we periodically check your intervention in order to revise your impression. So if they're satting poorly, and we put them on CPAP, then we're going to continually monitor and what we're expecting and hoping is that their SATs go up and that things are getting better. So if it doesn't improve, by monitoring this, then we know that some additional interventions that may be needed. They may be appropriate in these situations. One of the things that I'll make sure to warn you about is that last point, that's to avoid tunnel vision. In my opinion, one of the easier ways to do that is to always have a differential diagnosis. So what I mean by that, put it in just other terms and how your book has described it, is going to be CHF versus pneumonia. So, you're trying to determine which one of these two things it is. And as you do your physical exam and as you do your history and your note taking, it will start leading you one direction or another. So was it an acute onset of shortness of breath, or has it been going on for several days? Do they have a fever, or are they afebrile? Is it wet lung sounds or dry lung sounds? And as you answer these, you'll start whittling things down, and you're going to start kind of going down one particular side of the flow chart that you're kind of building in your mind for these different diagnoses. So making sure that we avoid tunnel vision, is a really important thing. And then our last stage, another bit of reflection, but that's when the call is over. So we sit down, as you can see these guys here, we're sitting down and we're talking, and maybe we're just doing it by yourself though. You're in your recliner for a minute, and you start to think, man, I thought this was going to be that, and I did this, and nothing helped, and we start really kind of second guessing and questioning what we did and why we did it, and that's good because we want to be able to learn on this. So we want to figure out what went wrong, what went right, talking about the way that a particular mass casualty or a bad trauma scene went with your partner is, hey, and the next time, let's make sure we, don't leave the truck without a backboard, and let's make sure we do this prior to that. Those are always good things. So some of the elements that contribute to critical thinking, and you're going to see we've talked a little bit about probably nearly a lot of these, but adequate knowledge of anatomy, physiology, and pathophysiology, the ability to gather and organize data and form concepts, the ability to focus on specific and multiple elements of data, the ability to identify and deal with medical ambiguity, the skill in differentiating relevant and irrelevant data. So you can also kind of think of when we talk about pertinent and non-pertinent negatives. So, it's important to know both sides of those things. And then the capability to analyze and compare similar situations, as well as compare contrary situations, and ability to articulate your reasoning and construct arguments. And you can look at all these different pieces, and some of it's just fact gathering, and some of it's processing it and assimilating, and some of it is reflection after you've done something. So these are all good things, and you probably, it's not that you sit down and you think, I'm going to do, this, but it's happening. Hopefully that it is happening, because for concerned caregivers, most of the time we're questioning what we did and why we did it. So from theory to practical application. So just from just a piece of paper that you see on the paper, or these PowerPoint slides, or me yapping at you, to really, how does this work? That's kind of what we're talking about. So each call has obviously very unique circumstances, and they all require appropriate care. They all require potentially something a little bit different. You need to move this direction, you need to move that direction, think about this, all of these things. So the changes in call variables will determine a paramedic's ability to manage that call, and that's kind of a big thing, is we need to understand that most of the time these calls are not the same, but we do need to handle them professionally. We do need to handle them in the best, making sure that we're giving the best care that we can. So, paramedics, we have to learn how to deal with our own reactions when dealing with extreme medical emergencies. And that kind of goes back to some of that tunnel vision stuff. When you get on a mass casualty scene and you're overwhelmed, this goes back to the duck thing and not getting into tunnel vision. So I believe that I mentioned it when we talked about patient assessment, but this is why we developed that strong systematic approach. So in the event our senses start to get overwhelmed, we're able to still continue on with our patient assessment, still power forward, and still get a good assessment done. So a checklist kind of to facilitate thinking under pressure. So when you're kind of overwhelmed and you're probably having to rely on some muscle memory to get things working, is one of the things, just scan a scene, see who you got, see what you got, see what's going on, stop and think. At the end of the day, guys, I want you to remember this. This is not your emergency. We're just players in this kind of this drama or this play, so to speak. We're there to help, but this is not our emergency. And we're not helping anybody if we take ourselves out of the game by getting wound up, getting focused in on things that don't need somebody to be focused in on them. And if nothing else, remember this, your ABCs. As long as we can maintain our ABCs, then we're going to give that patient a good shot at the next step, which the next step is getting them to a surgeon if it's a bad trauma call or whatever. But we need to understand, do they need us messing around with them on scene, or do they need to be put in the back of that truck and get to the local trauma center or level 1 trauma center or whatever the call is? And more than likely, they probably need a surgeon, so we need to get them there. So stop and think about what you're doing. Move forward, make decisions, and then act on behalf of the patient. And in my opinion, if we are always acting on behalf of the patient and meaning we're being a patient advocate, even if we're wrong, we're still kind of right, because unless we make a really heinous medical error, at the end of the day, we're doing what we believe is to be best for the patient. We may have to get educated on truly what's best for the patient, but if we think about that, I think most of the time we're going to make good decisions. So we also got to stay calm, maintain situational awareness, always know that whether your scene is still safe, know that you may have oncoming traffic, all of those things. And then talking about this checklist, last one is going to be continually reevaluate the patient. So when you're talking about just a one-on-one situation, you can't go wrong making sure you do your ABCs. You got lots of little pieces, so don't take this as verbatim of how to do this thing, but you obviously check your LOC, do your ABCs, manage any life-threatening wounds, and get going. And sometimes, I don't believe that I mentioned it in the assessment lecture, but there's going to be times you may not get past your primary survey. There's times where you're not going to get past that primary assessment because ABCs are taking up all your time. You don't have time to get to your secondary assessment, and that's okay. If you go into the trauma center with a tib-fib that's unsplinted, that's okay because you're having to manage the airway. So don't think that these things are just this black and white list that you have to do these things and check off all the boxes, because it's not. Now, if you have time to perform that secondary assessment, great. But if you don't give up time and give up airway issues or whatever so you can complete that secondary assessment. So now we kind of said we're gonna put in some application here. So let's just take it to the streets here. Let's remember the 6 R's of clinical decision making. They can help put a paramedic out on a call. So first thing is we're going to read the scene. So we know these scenes, they're just filled with tons and tons of information if we'll pay attention to them. But we've got to pay attention to all of this information that is readily available to us. It may be the environmental things. It might be hazmat scenes. It might be there's a lot of different things that it could be, but we need to pay attention to that. So first thing we're going to do is we're going to read the scene, determine, whether it's a mechanism of injury or nature of illness, but we're going to figure all these things out. Then we're going to then our next R, we're going to read the patient. So if you're able to, offer your hand and introduce yourself and shake hands. That gives you a little bit of idea, something about the strength of the patient. You're also able, if sometimes I've seen it done. I've never done it myself, but sometimes people will use their fingers and gather a pulse real quick, and you're able to tell right away if it's a nice, strong, and regular pulse. I'm not saying to hold it there for 15 seconds and count it and do all of that, but you're able to tell if they have a good, strong radial pulse, which we know tells us a little about blood pressure or perfusion, essentially. And then you're also able to address them appropriately, introduce yourself, and then address them. Right there, that's where we're going to go ahead and get our GCS score, right? Because if they know their name and they know what happened and they're able to tell you all of these facts that are correct, we're probably safe to assume that they have a good GCS, probably a 15. But then we're going to start observing the patient when we talk about reading the patient. So we're talking about a level of consciousness. We're talking about kind of their body positioning or their level of comfort or maybe discomfort. We're able to gather a lot just by their skin, aren't we? So we're going to talk about or think about rather looking at a perfusion status. So we know that if someone is pink, warm, and dry, that's a really good sign they have adequate perfusion. So we're going to take a good look at that. We're also going to look to see how they're breathing. We're going to see if they're struggling, if they're breathing really fast and very shallow, or maybe deep and fast. All the different patterns that we've talked about. Deformity. We're going to look to see if they have any deformities or asymmetries. Then we'll talk to them. We want to determine the chief complaint, get a good history. Start looking at their skin for color, temp, and turgor, assess their pulse rate, check their breath sounds, all of these type of things that we're talking about within our primary assessment. I want to get us some good vital signs so we can get to determine a baseline. Now remember, I think I've mentioned it, but if not, you'll hear it again and you're probably already aware of it. Critical patients are every 5 minutes, stable patients every 15 minutes. One thing that I ask is, regardless of really how sick or not sick the patient is, that when you're on clinicals that you'll get your first set of vitals, your blood pressure is essentially what I'm talking about, you'll get that with your stethoscope and your blood BP cuff rather than let the machine do it for you. I recommend this as you become a practicing paramedic. I recommend this for anybody that you believe is sick. Get you a good blood pressure that you know to be accurate, and that way, if the machine gives you a weird number, then you know really where you were at, so you need to check it again or whatever. But I just believe that it's a good practice to go ahead and get that first blood pressure manually by hand and then move from there. So the next thing we're talking about, we did kind of our ABCs. We're going to react is our next one you see on there. First priority, treat any life threats. And then consider a possible causes of the symptoms. So we're going to start developing our differential diagnosis and then moving on ultimately to gathering up our working diagnosis at this point. So if you're unable to do that, then we need to continue to narrow down these things and still provide care. But start hopefully narrowing down these signs and symptoms to start working upon a working diagnosis. Next step is going to be reevaluate. So we're going to follow up on any intervention. So, we noticed that they had a bad airway. We went ahead and intubated them, and we want to make sure that they're still satting good. We want to make sure that their skin color is changing appropriately. We want to make sure the tube is in the right place and that it's secured down. All of these things we just want to reevaluate all of the treatment modalities that we did, and then the next thing would be to revise. So we want to also make sure that, maybe we have them on a vent and our FiO2 is low, and we want to go ahead and crank that up a little more because their pulse ox is not at the FiO2 being your percentage of inspired O2. So we want to go ahead and bump that up. So say we had it at 50% and we want to bump it up to 60 or 70. Most of the vents that we use on scene calls like this are not going to have that function, but the event it does, we need to be able to critically think these things. Maybe we need to turn the rate up higher. If we have some capnography issues, we need to increase their rate to blow off some of that CO2. All of this stuff, though, is going to fall within your protocols. So however that falls within where you're at is going to be what's important, but we want to revise where we need to revise. And then our last step, we're going to review it. So once it's over, hopefully we're going to have a few minutes to be able to sit down. If nothing else, just while you're writing out your report or typing it out now, and figure out where, maybe notice a trend that we gave them some atropine and their pulse never went up, and maybe we didn't recognize that, or we overlooked that, or whatever. We even recognized it and just didn't care and just moved on because something else was more important. But this is the time that we kind of need to review that, start figuring out some things. Maybe we need to do a little debriefing with our partner and figure out why certain things happened on that call and what they were thinking. Because I can tell you, if you can get your EMT on board, if you work at a service and you have the luxury of working with the same EMT, which sometimes it's not a luxury, you know what I mean. But if you have the ability to work with the same EMT, you guys can really start forming that good team concept and know that, listen, I'm going to do the airway, you're going to work on the IV, I'm going to do this, you're going to do that, and then they're watching your back, you're watching their back. But as we know, as paramedics, at the end of the day, this is your deal. So you may choose to allow them to do some interventions, but at the end of the day, you're responsible for it because you're kind of not really the supervisor on the truck, but you are responsible for patient care. So that's going to be our last bit on reviewing performance. So when we talk about, hang on here. So we that's just me. I'm sorry. I was going over each one as we talked about it. So observe the patient, talk to the patient, touch the patient, all of these things. And then, simple debriefing, and then informal conversations with our partner. So kind of figuring these things out. So this will complete chapter, I guess we're on chapter 12, critical thinking and clinical decision making. So I'll see you next time.